Eye Movement Desensitization and Reprocessing, EMDR by Nahama Rosenberg. These are the topics that I'll be talking about in my presentation. Introduction to EMDR, the founder of EMDR, a way of being, the therapist's role and function, characteristics, values, boundaries, and relationship development, a way of understanding, the theories, basic assumptions, and key concepts for understanding human behavior, personality structure, normal and abnormal development, a way of intervening, treatment techniques, intervention, and procedures, is the use of eye movement necessary for EMDR, and multicultural considerations, and an art therapy directive. Introduction to EMDR. EMDR theory is based on the Adaptive Information Processing AIP model, which views associative memory or neural networks as the psychological basis of perception, cognition, emotion, and behavior in both health and pathology. According to the AIP model, the brain's information processing system are geared toward healthy adaptation for survival. Similar to how the body reflexively heals physical wounds, the mind-brain-body system is designed to extract adaptive information from life experience and disregard the rest. Dr. Francine Shapiro, an American psychologist, is credited with founding Eye Movement Desensitization and Reprocessing, EMDR, a form of psychotherapeutic treatment that uses bilateral stimulation through eye movement. In 1987, while making a chance observation, Dr. Shapiro noted that eye movements significantly reduced the intensity of disturbing thoughts and emotions. Since then, EMDR has developed rapidly and is now utilized by therapists worldwide. Research studies have shown that EMDR can accelerate the healing process significantly. A way of being. A therapist's role and function, characteristics, values, boundaries, and relationship development. Shapiro, the founder of EMDR, emphasizes the importance of the therapist-client relationship and rapport in the desensitization and installation phases of EMDR. Building trust and rapport may take additional time for more complex cases or clients with insecure attachment status. Van der Kolk suggests that attunement and resonance are crucial factors in the healing of trauma. While transference and countertransference may be less of a factor in EMDR than in eclectic therapy, therapist self-awareness is still essential. Some clients have described their relationship with their EMDR therapist, and resources are available for resolving therapeutic impasse, resistance, and countertransference in EMDR. Overall, the therapeutic relationship and the therapist's understanding of both the client and themselves are crucial factors in the effective use of EMDR. During EMDR training, therapists are instructed to assist clients in staying within the therapeutic window. If the reprocessing slows down or stops, the therapist can utilize techniques to improve access to memory networks. If the client experiences overwhelming emotional arousal, the therapist can use techniques to reduce the intensity of the emotions and enable the reprocessing to continue. It is crucial for EMDR therapists to be mindful of their own emotional states to maintain a positive therapeutic relationship. If a therapist's negative memory networks are triggered by the client's emotional shifts or the emergence of a distressing memory, they may either avoid the emotional intensity by continuing bilateral stimulation or push the client past their emotional tolerance, leading to a rupture in the therapeutic relationship. A way of understanding. The theory's basic assumptions and key concepts for understanding human behavior, personality structure, normal and abnormal development. The hallmark of EMDR is the assumption that psychologically stored memories are the primary foundation of pathology, with the primary agent of change being specifically targeted information processing. EMDR is a therapy approach that is based on the premise that trauma memories are abstracted from normal processing into semantic memory. In alignment with cognitive theories of trauma, the objective is to permit memories to enter semantic memory in a detoxified form, without being associated with potent negative emotions, physical sensations, and negative beliefs. The entire process, not only the eye movement manipulation, allows clients to re-experience the trauma differently, with a therapist setting up the process to ensure safety. The protocols focus on particular beliefs, emotions, and physical sensation guides the client towards new ways of processing the memory. The eye movement manipulation are believed to make the trauma memory less vivid, making it easier to process. By identifying and processing these dysfunctional memories, clients can experience a reconfiguration of the memory of trauma, often resulting in freedom from the disturbance the trauma memory generates, similar to post-traumatic growth. The AIP model provides a theoretical framework that both explanatory and predictive of positive treatment effects in various clinical populations beyond PTSD, with its assumptions and concepts being essential for understanding human behavior, including personality structure, normal and abnormal development, and the impact of trauma on the nervous system's information processing abilities. The AIP model posits that humans possess an intrinsic information processing system that has evolved to reorganize responses to disturbing events from an initial dysfunctional state of disequilibrium to a state of adaptive resolution. Trauma causes an imbalance in the nervous system as a result of stress hormones, leading to blocked or incomplete information processing. With this dysfunctional information being stored in its unprocessed state, identifying these dysfunctional information hotspots of unprocessed events is central to EMDR treatment, with processing resulting in a reconfiguration of the memory of trauma, with clients often experiencing a sense of emancipation from the disturbance the trauma memory generates, similar to post-traumatic growth. A way of intervening: treatment techniques, interventions, and procedures. There is an 8-phase protocol for eye movement desensitization and reprocessing therapy, EMDR. Here's a breakdown of each phase and what it involves. Phase 1 is history taking. During this phase, the therapist conducts a comprehensive assessment of the client's history, including past and current issues, and identifies salient issues that will be targeted in therapy. The therapist conceptualizes the case from an adaptive information processing AIP perspective, which assumes that the brain has a natural capacity for healing, but may get stuck in maladaptive patterns due to adverse life experiences. Phase 2 is preparation. In this phase, the therapist establishes a therapeutic relationship with the client and attunes to their needs. The client is prepared for the therapy by learning relaxation and coping skills, as well as accessing internal and external resources that can support them during the therapy. The therapist also helps the client develop affect regulation skills to manage any distress that may arise during the therapy. Phase 3 is assessment. The therapist identifies the disturbing target memory that will be the focus of the therapy, along with any associated negative beliefs and emotions. The client creates a positive belief statement to replace the negative belief, which is then linked with the target event and currently held emotions and body sensations. Phase 4 is desensitization. During this phase, the therapist activates the target material using bilateral stimulation, BLS, or dual attention stimulation, DAS. While the client focuses on the memory, associated emotion, and body sensations, the therapist guides the client to mindfully observe the process and any new insights or associations that may arise. This process continues until the level of disturbance is significantly reduced. Phase 5, installation. The therapist helps the client connect the positive belief statements with the target event so that the client experiences a sense of resolution and empowerment. Phase 6 is body scan. The therapist guides the client to scan their body for any remaining sensations related to the target event, positive belief statements, and bodily sensations. The client is encouraged to notice any changes in these sensations and to associate them with the positive belief statement. Phase 7, closure. The therapist ensures that the client is reoriented to the present and that any unfinished business is addressed before the end of the session. The client is taught self-soothing techniques to use in case of any residual distress. Phase 8 is reevaluation. The therapist evaluates the impact of the therapy on the client's functioning and reviews the overall care plan and target sequence. If necessary, the therapist revisits any unresolved issues and adjusts the therapy accordingly. Is the use of eye movement necessary for EMDR? Although the approach founded by Shapiro is named after eye movements, she has acknowledged that other forms of bilateral stimulation, such as finger tapping or auditory tones, can replace it. In fact, Shapiro has also suggested that EMDR can work without any external stimulation at all, albeit less effectively. Nevertheless, eye movement technique or other bilateral stimulation remains a central aspect of EMDR. According to John Spector, the technique induces a form of dual processing, in which the client attends to the bilateral stimulation while concentrating on the trauma memory. The therapist's skill in EMDR lies in holding the client in the middle ground between the past traumatic experience and the safety of the present therapy session, avoiding making them too uncomfortable or too unsafe to allow for effective processing. Multicultural considerations. Multicultural considerations in using EMDR are still under research. With much of the existing literature taking one of the two approaches, some studies have applied the standard EMDR protocol to new populations and found it effective in addressing trauma resulting from natural disasters. Other researchers have described case studies where adaptations to the protocol were made to serve the needs of specific cultural groups better. This lack of consistent information raises questions about the potential impact on EMDR clinicians. While international training efforts for EMDR clinicians seem to be considering cultural variables, there is a lack of empirical research in the area, making it challenging to develop a structured approach to multicultural considerations in EMDR. Integrating evidence-based practice and culturally sensitive counseling may lead to better client outcomes, but the current discourse often portrays these approaches as opposing. This misrepresentation may influence future practice and perpetuate the divide between evidence-based practices and multicultural considerations. Art Therapy Directive. This therapeutic approach utilizes various techniques to address traumatic stress, such as dual attention focusing, heightened somatic awareness, and art making. It guides clients through layers of unresolved past material by creating art and focusing on bodily sensations, accessing previously defended affective material. Ongoing bilateral, tactile, and auditory stimulation is used to facilitate the process and transform distressing memories with new associations to adaptive and positive information. The client selects a disturbing memory and identifies an image, negative self-referencing belief, and accompanying emotions and sensations. Bilateral stimulation is initiated through headphones and a handheld pulsating device placed under each knee while the client draws an image of the traumatic events. Sets of sequential bilateral stimulation are used during the art-making process to facilitate the emergence of new cognitions and awareness. The resulting series of images visually track the client's progress and provide a useful tool for further verbal processing and resolution. For example, the client is a woman who experienced sexual assault as a teenager. She may have developed a negative self-belief that she is to blame for what happened to her. In the therapy session, the therapist guides her to draw an image of the traumatic event and the negative belief associated with it. She may draw a scene of herself being assaulted and feeling helpless and write, "I am to blame" next to it. This integrated approach has successfully treated both complex and single-event trauma, resulting in rapid and often dramatic shifts in awareness and perception. This process is titrated with short and longer sets of bilateral stimulation, art making, and brief interventions by the therapist to clarify issues and access more adaptive associations. These associations give way to new perceptions and understandings of the targeted memory from an adult perspective.